I speak to you as a clinician scientist who studies vascular biology and men's health. Over decades of reading trial data, examining physiology, and treating patients, I have developed a simple working principle. Sexual function, particularly erectile function, is a window into vascular health. When blood vessels fail, the signals that produce an erection fail as well. In recent years, popular media has simplified this complex reality into pithy prescriptions. Add X vitamin to water and your manhood returns. My objective today is not to sell a ritual. It is to interrogate mechanisms, weigh trial evidence, and delineate what the preclinical and clinical literature actually supports about specific micronutrients. I will use a rigorous, evidence-first lens, and I will tell you plainly where the science is strong, where it is promising, and where it remains speculative. Erection is fundamentally a vascular phenomenon. It requires intact endothelial function, adequate nitric oxide, NO, synthesis, healthy arterial inflow, unobstructed venous outflow, intact peripheral nerves, and coordinated hormonal signaling, especially testosterone. Risk factors that damage blood vessels, atherosclerosis, diabetes, hypertension, smoking, also produce erectile dysfunction, ED. Thus, any nutrient that meaningfully modifies endothelial function, oxidative stress, vascular calcification, or hormonal axes could plausibly influence erectile physiology. But plausibility is not proof. Randomized controlled trials, RCTs, are required to determine whether an intervention produces a clinically meaningful change in erectile outcomes. Key practical point. For a clinician or scientist, the most actionable approach is to consider nutrient interventions when there is either A, a clear mechanistic rationale, plus supporting human data, or B, documented deficiency in the individual patient. Absent those, routine high-dose supplementation is unlikely to substitute for diagnosis and treatment of underlying vascular disease. Vitamin D, measured as serum 25-hydroxyvitamin D, functions more like a hormone than a classic dietary vitamin. It modulates immunity, inflammation, and cellular signaling, and influences endothelial cell function and systemic inflammation. Observational studies repeatedly show an association between low vitamin D status and higher prevalence of ED and of cardiometabolic disease. Mechanistically, vitamin D sufficiency correlates with better endothelial nitric oxide synthase, or NOS function, lower inflammation, and, possibly, improved androgen synthesis via central and peripheral pathways. Yet observational association does not equate to therapeutic effect of supplementation. Large randomized trials have tested whether vitamin D supplementation prevents or improves ED and related vascular outcomes. Notably, the D-Health randomized trial reported that 3 years of vitamin D supplementation in older men did not produce a measurable improvement in erectile dysfunction prevalence compared with placebo. The implication is immediate and important. While vitamin D deficiency is common and biologically plausible as a contributor to ED, blanket supplementation among older men does not in itself reliably restore erectile function for the population at large. Targeted correction of deficiency remains reasonable, but vitamin D alone is not a universal cure. Clinical takeaways. Measure serum 25-OHD before supplementation in older men presenting with ED. Correct documented deficiency with supervised dosing, for example, initial repletion followed by maintenance, because correcting deficiency can have broad health benefits. Do not expect vitamin D monotherapy to restore erectile function in patients with established vascular disease or multifactorial ED coexisting. Pathologies must be addressed. Vitamin C, ascorbic acid, is a major, water-soluble antioxidant and an essential cofactor for collagen synthesis. Within the vasculature, vitamin C can preserve tetrahydrobiopterin, BH4, a critical cofactor for enos. BH4 stabilization prevents ENOS uncoupling, a pathological state in which ENOS produces superoxide rather than nitric oxide, diminishing vasodilation. By decreasing oxidative inactivation of NO, vitamin C theoretically supports endothelial-dependent vasodilation. Meta-analyses and clinical trials show more consistent benefit for vitamin C on surrogate measures of endothelial function, such as flow-mediated dilation and arterial stiffness, particularly among patients at higher cardiovascular risk, for example, those with diabetes or hyperlipidemia. Trials specifically measuring erectile outcomes are fewer and smaller, but the accumulated data indicate that vitamin C improves endothelial parameters that are mechanistically relevant to penile blood flow. Systematic reviews indicate improved endothelial function after vitamin C supplementation in at-risk populations, though the translation into consistent, robust erectile improvements across heterogeneous populations remains incompletely established. Oral vitamin C at moderate doses, for example 200-500 mg a day, is generally well tolerated. High-dose intravenous vitamin C, used in oncology research for different mechanistic reasons, is outside the scope of routine ED therapy and carries different pharmacodynamics. In clinical practice, vitamin C is safely considered as part of a broader antioxidant strategy for patients with oxidative stress-driven endothelial dysfunction, but it should not replace evaluation and management of cardiovascular risk. Vitamin K2, menaquinone, and particularly the MK7 isoform, activates matrix Gley protein, MGP, a potent inhibitor of vascular calcification. The biological logic is clear. MGP requires vitamin K-dependent gamma carboxylation to function. Adequate K2 availability facilitates removal of calcium from soft tissues and directs calcium deposition to bone rather than arteries. Because arterial calcification is a structural and progressive process, trials testing K2 focus on progression rather than rapid reversal. Randomized trials and controlled studies produce mixed results. Some RCTs and cohort studies report slower progression of calcification or improved surrogate markers with K2 supplementation, while others, especially in particular patient subsets and at specific doses, have not shown benefit. Large trials in specific high-risk populations, for example, patients with significant baseline calcification or hemodialysis patients, have had variable results. The mechanistic expectation that K2 may retard progression of calcification is supported by some trials, but K2 is not a guaranteed or immediate restorative therapy for established arterial calcification. If penile arterial compromise is partly driven by calcific arteriopathy, then slowing calcification progression could, over the long term, help preserve penile perfusion. However, demonstrating an effect of K2 on erectile outcomes requires long, well-powered trials designed for sexual health endpoints, which are currently limited. Importantly, K2 interacts functionally with the coagulation system. Patients on vitamin K antagonists, e.g., warfarin, must not change K2 intake without close medical supervision. Vitamin E, tocopherols and tocotrienols, is a lipid-soluble antioxidant that protects cell membranes from lipid peroxidation. Within vascular biology, this effect stabilizes endothelial and smooth muscle cell membranes and may reduce oxidative inactivation of NO. Given that oxidative stress is central to endothelial dysfunction, vitamin E has theoretical utility. Trials of vitamin E alone for cardiovascular outcomes have been inconsistent. Some large trials failed to show benefit and raise safety signals at very high doses. However, when vitamin E is combined with other antioxidants, for example, vitamin C, flavonoids, or herbal agents, several smaller trials and meta-analyses focused on ED report clinically meaningful improvements in erectile function scores relative to placebo. A recent systematic review of antioxidant supplementation for ED concluded that antioxidant regimens, often multi-nutrient, were associated with improved erectile function, particularly in men with more severe baseline ED. The heterogeneity of supplements, doses, and patient populations complicates interpretation. High-dose vitamin E, 400 IU day in some older meta-analyses, has been linked to potential adverse outcomes in specific settings. Therefore, clinical use should favor moderate doses within established safety margins and emphasize combined lifestyle and medical management rather than high-dose monotherapy. Beyond the 4 vitamins above, several other nutrients have mechanistic or trial support relevant to vascular health and male sexual function. Zinc is critical for testosterone synthesis and spermatogenesis. Observational data link zinc deficiency to hypogonadism. Supplementation corrects deficiency and may improve testosterone concentrations in deficient men. Randomized data specifically linking zinc to improved erectile function are limited, but in men with documented zinc deficiency or marginal intake, correction is reasonable. Magnesium supports endothelial function, insulin sensitivity, and blood pressure regulation. Some observational and interventional studies suggest magnesium supplementation lowers blood pressure and improves endothelial markers, which are indirectly relevant to erectile physiology. Again, correction of deficiency is primary clinical logic. Coenzyme Q10, CoQ10. CoQ10 participates in mitochondrial electron transport and is a potent antioxidant in lipid membranes. Trials in cardiovascular disease and heart failure show improvements in functional capacity and oxidative stress. Limited trials of CoQ10 in ED exist. However, CoQ10's role in improving endothelial health and cellular energetics suggests plausible benefit, particularly in metabolically compromised men. Omega-3s improve endothelial function, reduce triglycerides, and have anti-inflammatory effects. Some studies in animal models and small human cohorts demonstrate improved penile blood flow after omega-3 supplementation. Larger trials focused on sexual outcomes are lacking, but omega-3s remain reasonable as part of cardiovascular risk reduction. L-arginine is a substrate for no production. Trials combining L-arginine with antioxidants or PDE5 inhibitors show additive benefits for some men with ED, especially when endothelial dysfunction is a dominant factor. However, dosing, tolerability, and heterogeneity of responses warrant clinician supervision. Synthesis of these practical data. Collectively, these nutrients are not miracle cures but biochemical tools. When deficiency or metabolic dysfunction is present, targeted supplementation, combined with lifestyle change and appropriate pharmacotherapy, can produce measurable benefits in endothelial function and, by extension, sexual function. As a researcher-clinician, here is the stepwise approach I use and recommend. Comprehensive assessment. Check cardiovascular risk, BP, lipids, HbA1c, testosterone, thyroid, renal function, and specific nutrient levels, 25-OHD, if indicated, serum, zinc, magnesium. ED often signals systemic disease. Lifestyle optimization as first-line therapy. Exercise, aerobic plus resistance. Smoking cessation, Mediterranean-style diet, weight loss, sleep optimization. These have the largest, most reproducible effects on vascular and sexual health. Targeted supplementation. Correct documented deficiencies. For endothelial dysfunction with oxidative stress, consider a rational antioxidant strategy. Vitamin C, vitamin E at safe doses, dietary polyphenols, not indiscriminate megadosing. For calcification risk and bone health, discuss K2 with attention to anticoagulant status. For low vitamin D, correct deficiency with monitored D3 replacement. Objective monitoring. Use validated tools, IIEF scores, Measure biomarkers and reassess after a defined interval, e.g., 8-12 weeks, to gauge response. Escalation to evidence-based pharmacotherapy when indicated. PDE5 inhibitors, testosterone replacement, only if hypogonadal and after endocrine evaluation, or referral for vascular imaging or urology evaluation if conservative measures fail. This algorithm emphasizes a disciplined, evidence-based use of micronutrients. Supplements are adjuncts, not substitutes. For diagnosis and established therapies. The evidence gaps are clear. We need large, well-designed RCTs that target men with defined pathophysiology, for example, endothelial-dominant ED versus neurogenic ED. Use standardized doses and formulations, e.g. MK7 versus other K2 isoforms. Defined organic forms of vitamin E. Specific CoQ10 formulations include long-term vascular and sexual endpoints, not only surrogate markers. Explore combination strategies, e.g. D3 correction plus antioxidant regimen plus lifestyle versus monotherapy. Until such trials exist, clinicians should combine physiology, deficiency correction, and standard therapies. What then is the honest conclusion? Vitamins and micronutrients have biologic plausibility, and, when deficiency exists, correcting them is medically sensible and often beneficial. Vitamin C supports endothelial function. Vitamin D correction restores metabolic milieu in the deficient. Vitamin K2 may slow calcification progression. Vitamin E and broader antioxidant regimens can improve oxidative stress-driven dysfunction when used judiciously. Yet none of these are single-agent, rapid cures for age-related ED across all men. Responsible practice requires assessment, targeted correction, lifestyle change, and evidence-based escalation. My final practical admonition to clinicians and patients: evaluate before you supplement. Treat the person and the disease, not the narrative, and view supplements as components in a system of care rather than as quick fixes. If today's deep dive helped you see men's health through a clearer, more scientific lens, don't let the conversation stop here. Hit subscribe and turn on notifications, because next, we'll unpack the real molecular stories behind testosterone decline, vascular aging, and how nutrition, sleep, and microcirculation truly intersect. And if you believe more men deserve facts, not myths, about how their bodies work, share this video. Let's build a smarter, evidence-driven community that values science over superstition. I'm the Stories Helty, and as always, stay curious, stay critical, and take care of your biology.